Subcommittee on Information Technology and the Subcommittee on Healthcare Benefits and Administrative Rules will come to order. Without objection, the chair is authorized to declare a recess at any time. We're expecting votes fairly soon, so I'm hoping that we can get through opening remarks, go do our vote series, and come back and finish the hearing. Good afternoon. Appreciate y'all being here today. Y'all know, y'all are in this space, that heart disease is the leading cause of death in the United States, according to the CDC. More than 600,000 Americans die from heart disease each year. The American Medical Association recommends walking as the simplest positive change you can make to improve your heart health. Walking 30 minutes a day, or around 10,000 steps, lowers blood pressure, improves mood and mobility, and increases energy. Simply increasing the number of steps you take per day can significantly reduce your risk of coronary heart disease and stroke. Many of you could glance right now at your smartphones, wearables, or other devices and report your number of steps and calories burned for the same periods of time. And for most of us, I'll bet that number is probably higher than before we had the app or device and we were tracking our steps. It would not be an extreme exaggeration to say that the proliferation of wearable devices and smartphone apps that track steps and the accompanying increases in the number of steps some people are taking on a daily basis has saved lives. This is just one example of the benefits technology has brought to health and healthcare, and we have barely scratched the surface. We are on the cusp of being able to use technology to truly revolutionize healthcare and healthcare delivery. Leveraging the power of the cloud will enable us to move more healthcare tasks online, including consultations and data storage and retrieval. Censos will make it easier for people to take care of themselves before they get sick. Constituents in rural parts of Texas 23rd, my district, will be able to speak directly with their primary care providers instead of commuting hours each way. As more devices are connected and more data is generated, medicine will become customized and personalized. Preventative medicine and healthy living practices will increase, costs will decline, and the prevalence of chronic diseases will decrease substantially. But this will only happen if researchers, hospitals, entrepreneurs, regulators, healthcare professionals, patient advocates, and lawmakers come together to update antiquated laws and reform outdated institutions. Right now, old and unclear privacy laws hinder interoperability between health IT systems and devices. Right now, the sheer number of federal agencies and often conflicting rules one must navigate to invest in this space chills investment and entrepreneurship. And right now, a fragmented and bureaucratic system places the patient at the fringe of the process rather than at the center. In today's hearing, I hope to hear specifically what laws or regulations need to be changed or updated and how they should be changed or updated or abandoned. Health IT is an exciting, innovative field. But to get this right, we must collaborate, we must destroy silos. I'm committed to doing so. I know my friend and ranking member, Ms. Kelly, and Ted Lieu is as well, and I want to thank the witnesses for being here today, and I look forward to their testimonies. And now I'd like to recognize Mr. Cartwright for his opening statement.
Thank you, Chairman Hurd, and I'd like to thank you both for calling this hearing so we can hear about how the federal government and private industry are working together, and for your interest and efforts at creating the next generation of health information technology. I represent largely a rural district in northeastern Pennsylvania, and I know quite well how health IT can bring affordable medical care to those who might not otherwise be able to receive it. In fact, that's why I co-sponsored the Medicare Telehealth Parity Act of 2015, the 21st Century Cures Act, and also the Telemed Act. Bills like these help medical professionals provide patients with the best health care available anywhere and at any time. But even with the undeniable benefits technology brings, patient safety must remain our foremost consideration. Technology brings opportunity, but it can also bring unforeseen challenges, and I hope we can talk about that a little today. As a career courtroom attorney, I have seen too many medical malpractice lawsuits where carelessness caused injuries and death, and where doctors have made grave and avoidable mistakes, and too often these mistakes were due to failures in communication that left physicians and nurses without all of the patient's information that they needed to complete proper assessment and treatment. We worry that different computer systems, standards, and methods of tracking medical history often mean doctors, nurses, lab technicians, and others involved in the treatment process cannot get a complete understanding of the illness in front of them and the treatment that's needed. That's why it is so important that technologies like electronic health records, which contain the complete medical and treatment history of a patient, quickly and efficiently give providers insight and a comprehensive view into what's going on and all of the facts of the case. Standardized, industry-accepted technologies can make that happen, in my view. In the field of health IT, private industry has a critical role in the process, doing what it does best, drive innovation, and keep America at the leading edge in medical technology. The federal government also has a role to play, making sure these new technologies meet healthcare needs without compromising patient safety. I'm looking forward to today's hearing, to the testimony of all of you. I'm glad that industry and government are working together to bring about the kinds of technological advances that will improve healthcare in this country, make it safer, and make it more available to people in all corners and all pockets of this nation. I thank you again, Chairman Hurd, and I yield back.
Thank you, and I'm going to hold the record open for 5 legislative days for any members who would like to submit a written statement. And Ranking Member Liu is here, and if he is ready, we'll have him give his opening remarks. Mr. Liu from California is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you to the witnesses who will be presenting today. Today, we're here to learn more about how to make the primary health technology laws work smarter and better. Laws and regulations should be there to protect the public, but done incorrectly, they can hinder innovation, and the same holds true in the health IT space. The Healthcare Insurance Portability and Accountability Act, HIPAA, contains provisions to create universal electronic medical records and protect patient privacy. The Health Information Technology for Economic and Clinical Health Act, HITECH, contains provisions to protect consumer privacy and give notice in cases of data breach. The Affordable Care Act also contains provisions to improve the quality and efficiency of patient care with ECRs. However, these laws and regulations were enacted before key technological advances that we now take for granted. HIPAA was passed in 1996 before broad adoption of the mobile revolution. HITECH was passed in 2009 before much of cloud computing existed. Some might suggest that rolling back regulation is the answer, and while I agree that government regulation is not as nimble as technology, we still need some combination of regulations and enforceable guidance to protect the public. For instance, last month, the IT system at Hollywood Presbyterian Hospital in Southern California was held hostage by ransomware denying patients and providers access to their medical records. The HITECH law has cybersecurity requirements and requires notification for data breaches, but the law says nothing about notification for data that was frozen or held hostage where it is stored. I note that today, press reports that 2 more hospitals in Southern California were hit with malware attacks. Technology has moved very quickly. Telemedicine, text messaging, and the mobile smartphone explosion requires that HHS and FTC keep up with technology changes, update guidance reliably, and keep rules and regulations flexible to encourage innovation. Regulation done wrong or too little regulation makes it difficult to protect the public and ensure that data flows freely. Regulations done right spurs innovation, improves quality of care, and protects the public. I look forward to hearing from the witnesses today about what we can do to encourage innovation and cooperation and continue to bring government and healthcare into a more modern era of service. And with that, I yield back.
Thank you, Mr. Liu. And if Chairman Jordan joins us and is interested in giving opening remarks, we'll let him do that as he arrives. Again, I'd like to thank the witnesses, and I'd like to recognize y'all now. I'm pleased to welcome Dr. Karen DeSalvo, National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. Thank you for being here. Ms. Jessica Rich, Director of the Bureau of Consumer Protection at the U.S. Federal Trade Commission. Mr. Matthew Quinn, Federal Managing Director at Intel Healthcare and Life Sciences. Mr. Neil Crescenzo, did I say that? Crescenzo, member of the Executive Committee at the Healthcare Leadership Council, and Mr. Mark Savage, Director of Health, IT Policy and Programs at the National Partnership for Women and Families. Welcome to you all, and pursuant to committee rules, all witnesses will be sworn in before you testify. Please rise and raise your right hands, please. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Thank you. Please be seated. And let the record reflect that the witnesses answered in the affirmative. In order to allow time for discussion, please limit your testimony to 5 minutes. Your entire written statement will be part of the record. And we're going to go through as many opening remarks as we can before we get called to votes. If the bells go off while you're in your remarks, go ahead and continue, and we'll finish after your remarks. And now, I would like to recognize Mr. Salvo for your opening remarks.
Thank you, Chairman Hurd, and Ranking Members Liu and Cartwright, and distinguished members of the subcommittees. Thank you all for the opportunity to appear here today. I am Dr. Karen DeSalvo, and I have the honor of serving as the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services for the past 2 years. I'm proud to be here today representing the remarkable team at the Office of the National Coordinator and share with you the current state of health information technology in our nation and how we're working with others to see that these systems realize their full potential. The Office of the National Coordinator for Health Information Technology has a strong bipartisan history. It was established in 2004 by executive order and charged with the mission of giving every American access to their electronic health information. In 2009, it was statutorily established by the Health Information Technology for Economic and Clinical Health Act, or HITECH, which provided the resources and infrastructure needed to foster the rapid nationwide adoption and use of health IT. In the 7 years since HITECH was enacted, we've seen dramatic progress. Today, nearly all hospitals and more than 3/4 of physicians report using a certified electronic health record. This tripling in rates of adoption puts us as a nation well ahead of our peer countries, giving us significant competitive advantage in healthcare, innovation, and scientific advancement. And it is working in so many communities across this country. But I also know that we haven't realized the full potential of health IT for every person in this country. And this is not just an abstract policy idea to me, it is personal. It's why I came to ONC 2 years ago, because I knew as a doctor the promise of health IT, of having information available for me when I was on call in the evening, not at the hospital. Such a leap from the days in the early 90s when I was a medical student at Charity Hospital and had to physically go up to a lab and pull a lab slip with handwritten results from a wooden box so that I would understand more about my patients and how to care for them. Today, that's all available electronically to me and other doctors, and not just to us, but to our patients, to really see that they can be empowered and have the information they need to self-care. It's a rapid and remarkable transformation in a very short period of time. But the pace has come with challenges. Like others, I have been frustrated by the lack of interoperability, by the usability of the systems, and by how hard it can be to select the right system to buy. I hear about these challenges from my colleagues, whether in listening sessions, but also from consumers and other stakeholders. We all want to move ahead with the technology, but we want it to work better, and that's what I came to Washington to do. Since I've been the national coordinator, we have been focused on fixing those challenges in an urgent fashion to meet the expectations of the people that I serve, the American people. ONC does this in a variety of ways. For example, we can leverage our electronic health record certification program. We also serve as a coordinator across the federal government to see that agencies have shared policy and technology approaches and will send clear signals to the private sector. We've also worked with the private sector on setting a clear path ahead for our nationwide interoperability. This roadmap that we produced last year lays out who should do what by when to achieve interoperability in the near term to see that electronic health information is available when and where it matters to consumers and clinicians. ONC and others have been meeting our deliverables from this plan and are advancing drivers of interoperability like payment reform, publishing clear standards, working with states and others on harmonizing privacy and security expectation. The plan has been publicly endorsed by our federal partners, by the private sector, and we've been so pleased with everyone's willingness to step up and lead where appropriate to see that we can innovate and accelerate interoperability. Indeed, working with the private sector is how ONC operates. As another example, we recently convened stakeholders to ask them to make a series of commitments to ensure that electronic health information works better for patients and providers. It's a really tremendous opportunity for the private sector to lead. And so last month, we were able to announce that companies that provide electronic health records for 90% of hospitals in this country and healthcare systems with facilities in 46 states, including the states for all of the members of these two subcommittees, and over a dozen professional associations and stakeholder groups like the AMA and the American Hospital Association, all have agreed to implement 3 commitments that will help make sure health information flows. The commitments are that consumers will have access to their electronic health information, that entities will not engage in health information blocking, and that we will move to federally recognized national standards so that all these different systems will speak the same language. ONC and our partners in the federal space and the private sector are working together each and every day to see that we can move this future vision to an immediate reality. And Congress has been one of the great partners in health IT, and I look forward to continuing to work with you all to realize the full potential of health IT for this country. Thank you for having me here today, and I look forward to your questions.
Thank you, Dr. DeSalvo. Now, Ms. Rich, you're recognized for 5 minutes.
Chairman Hurd, Ranking Members Liu and Cartwright, and members of the subcommittees. I'm Jessica Rich, Director of the Bureau of Consumer Protection at the Federal Trade Commission. I appreciate this opportunity to present the Commission's testimony. Consumers are increasingly taking an active role in managing their health data, and there's been an explosion of new products and services to help them. These range from wearable fitness devices like Fitbit or Jawbone, to dieting apps like MyFitnessPal and Calorie Counter, and to websites like WebMD, where consumers can get health advice and information. These products and services offer enormous benefits to consumers, but they raise privacy and security concerns too. Who has access to all of this data, and is it being stored securely? Much of this activity now happens outside the doctor's office and other traditional healthcare contexts. As a result, it's not protected under HIPAA, which only applies to health data held or generated by covered entities, such as healthcare providers and health plans. In most instances, however, this activity is covered by the Federal Trade Commission Act, which prohibits unfair or deceptive practices across the marketplace, including in the area of health privacy. As the primary federal agency charged with protecting consumer privacy, the FTC has made it a priority to protect consumer-sensitive health information. Our efforts include civil law enforcement, policy initiatives, and consumer and business education. 3 recent FTC cases illustrate the challenges we faced in protecting consumers' health data and how the FTC is addressing them. PaymentsMD is a medical billing company that offered an online portal where consumers could pay their bills. The FTC charged that the company misled thousands of consumers who signed up by failing to tell them that it would also seek their highly detailed medical data from pharmacies, medical labs, and insurance companies. Henry Schein provided office equipment software for dental practices. We charged this company with misrepresenting to clients that its software provided industry-standard encryption of sensitive patient information as required by HIPAA. In fact, we alleged the software used a weaker method of data masking that didn't meet HIPAA standards. A third example is our settlement with GMR, a medical transcription service. We charged that GMR assured its clients that its services were secure, but outsourced them to a third party service provider without adequately checking its security measures. As a result, consumers found doctors' notes of their physical examinations freely available on the internet. Besides enforcement, the Commission engages in policy initiatives to encourage stronger protections for health information. Last year, we hosted a public workshop on consumer health data to examine the products and services consumers are using to generate and control their data and how this data is protected. We also released a staff report on the Internet of Things, which, among other topics, examined the privacy and security issues raised by connected medical devices and health and fitness products. Of greatest concern, panelists discussed the unique risks if health devices like pacemakers and insulin pumps are not secure and vulnerable to hackers. Finally, the Commission promotes stronger data protections through consumer education and business guidance. For example, our new identitytheft.gov website provides customized advice to consumers who have been victims of medical identity theft. And last year, the FTC launched its Start With Security campaign to educate small businesses around the country about how to develop an effective data security program. In addition, working with HHS and with FDA, the FTC is currently developing business guidance for health app developers to help them understand which legal requirements apply to them. The FTC shares the subcommittee's concerns about the need to protect the privacy and security of consumers' health data. Although we now use a variety of tools to protect consumers in this area, additional tools would enhance our ability to do so. To this end, the Commission reiterates its longstanding bipartisan call for federal data security and breach legislation that would allow us to seek civil penalties to deter unlawful conduct and give us jurisdiction over nonprofit entities. In closing, the FTC remains committed to protecting consumer health data and looks forward to our continued work with Congress on this critical issue. Thanks again for the opportunity to provide the Commission's views today.
Thank you, Ms. Rich. Mr. Quinn, you're recognized now for 5 minutes.
Good afternoon, Chairman Hurd and other esteemed members of the House Oversight and Government Reform Committee. Thank you for the opportunity to testify today on behalf of Intel Corporation. In my written testimony, I provide some tangible examples of how Intel is working to make good on the promise of today's health technologies and to pave the way toward tomorrow's. Today, I'd like to frame my comments in the context of recent personal experiences. 2 Fridays ago, I received the call that no one wants. My sister in Ohio said that Dad had just taken a bad fall. He had just left his doctor's office, where he was in for a checkup after a recent hospitalization. Things had gone well, and they stopped by a favorite restaurant for breakfast. As my dad climbed the curb, he became lightheaded, fell to the ground, and tumbled back into the parking lot. As we soon found out, he broke his clavicle, pelvis, and deeply cut his elbow. To say that my dad is a complex patient would be an understatement. He's the poster child for needing all of his providers and caregivers to be on the same sheet of music and to have the whole picture of his health and health care. Let's begin by thinking of the constellation of my dad's health data. Most familiar are the clinical and claims data captured at clinics, hospitals, and the like. Secondly, there is diagnostic data captured by medical devices and imaging. Adding to this is consumer-generated data. And finally, there is omics, vast amounts of information in his genome. Personal precision medicine in the 21st century will need to make sense of all of this. The U.S. has made great strides to ensure that each person has an electronic health record, yet the goal of point-of-care and personal access to comprehensive health information has not yet been achieved. There are 3 recurring barriers that often limit data sharing. First, medical institutions using privacy and security policies and laws like HIPAA as excuses for why they can't share. Next, medical professionals lacking easy, affordable tools to share data, especially because vendors fail to use or consistently implement standards. And finally, payment reforms that don't reimburse for new care models like telehealth. Back to my dad's experience. When he arrived at the ER of the same hospital where he had received his most recent treatment, they pieced together his health history, partly from the EHR and partly from my parents. I fear that if he was brought to a different hospital, it would have been basically starting from scratch. There exists a local health information exchange, but evidently, this hospital and my dad's nephrologist don't participate. My mom is our de facto health information exchange. My dad would definitely enjoy the kind of secure, standards-based data sharing that Intel's own Connected Care program makes available for over 33,000 of its employees. As we've shown, it's all quite possible today, just not widespread as it could be. We need to think about interoperability in much broader terms than merely the exchange of electronic health record data. That will change as the Internet of Things takes hold and we connect smart devices to the Internet in ways that generate data that can be turned into valuable insights. How would this affect my dad? Well, first of all, it would allow him to get some sleep. Because the devices monitoring him in the ICU don't talk to each other and his vitals tend to bounce around, there are endless, nearly always false alarms. What if devices, even from different vendors, could talk to each other? Innovators could create smart alarms from the new combined data streams and save countless hours of nursing time, countless lives, and just let my dad sleep. The data from all the medical devices could automatically feed the EHR, millions more nursing hours saved. But let's think bigger. What if when my dad was discharged that he was outfitted with sensors or an app that constantly detected whether his gait was making him prone to falls? Or what if, instead of having to drive across town to visit his doctor, he could do so from his home via telemedicine, and his blood and vitals could be automatically analyzed via his home dialysis unit? What if his caregivers could track his progress in getting back up on his feet as he rehabs? I think we've come up with half a dozen ideas for new businesses, but all of this relies on there being a solid foundation for the Internet of Things to blossom. Security from the sensor to the cloud, connectivity allowing devices to communicate their status to the system, data normalization to allow devices to speak the same language, and actionable analytics. So to close, how do we believe Congress can help seize the opportunities and overcome the challenges? First, sustain momentum towards standards and interoperability for today and for tomorrow. As Intel's Connected Care program demonstrates, a rigorous, standard-based approach enables quicker and more rapid, efficient deployments today. And to rapidly move forward toward the Internet of Things, Intel invites active federal participation in industry-led initiatives such as the IIC, OCF, ICE Alliance, and Continua. Second, encourage patient engagement by removing obstacles for patients to access and share their data. Intel invites policymakers to partner with industry to pursue a standardized machine-readable consent form to allow patients to easily donate their data to ongoing research. And last but not least, continue to push toward value-based care. We support the HHS goal to move half of care to alternative payment models by 2018. When incentives are aligned toward value-based care, the demand for information sharing goes up. Congress can further drive innovation by providing reimbursement for remote patient monitoring and other promising technologies. Thank you, and I look forward to your questions.
Mr. Quinn, appreciate your opening remarks. Now, Mr. Cenzo is recognized for 5 minutes.
Thank you, Mr. Chairman. Members of the committee, it is a privilege to be here today. My name is Neil Cenzo. I'm the President and CEO of Change Healthcare. Perhaps our name says it all. Change Healthcare is headquartered in Nashville, Tennessee, provides its services in all 50 states, and has over 50 offices nationwide. We are a leading provider of software and analytics, network solutions, and technology-enabled services that optimize communications, payments, actionable insights that enable smarter healthcare. By leveraging our intelligent healthcare network, which is one of the largest financial and administrative networks in the United States healthcare system, payers, providers, and pharmacies are able to more effectively manage complex workflows that support value-based healthcare. While I'm proud to represent the nearly 7,000 people of Change Healthcare, I am testifying today in my role as a member of the Executive Committee of the Healthcare Leadership Council, a coalition of leading companies and organizations from virtually every sector of American healthcare. In that role, I would like to share a few thoughts on the role and capability of health information technology to transform our nation's healthcare system for the better. As is increasingly the case in most fields, healthcare improvement today is driven by data. And if our healthcare system is not improving at the pace any of us would like, this is, in large part, due to barriers standing in the way of access to data, the ability to share information, and the utility of this information for consumers, providers, payers across the healthcare continuum. Our HLC member companies know from firsthand experience that data interoperability can strengthen care coordination, enabling providers, payers, pharmacists, laboratories, and others to be on the same page when treating a patient. It can boost progress toward an outcome-driven, value-based payment system to replace the outdated and inefficient fee-for-service status quo, while also improving our quality measurement capabilities. With interoperability and access to clinical and claims data, we can accelerate medical research and give hospitals and physician offices real-time access to comparative effectiveness findings. An interoperable system can improve care to rural and underserved areas of the country through improved telehealth and remote patient monitoring. Wellness and prevention will also be enhanced through the better use of patient-generated data. This future is promising, exciting, and eminently attainable once we address some of the obstacles standing in our way. Last year, HLC, under the auspices of its National Dialogue for Healthcare Innovation initiative, brought together leaders from over 70 organizations representing government, industry, patients, employers, and academia. There we built consensus on how we can move closer to this desirable, data-driven future. Last month, we announced the consensus recommendations emerging from this effort, a number of which are relevant to today's discussion. On data interoperability, we believe that a firm date of December 31st, 2018 should be established by which health information is widely shared among electronic health record systems nationwide. We have the capability to reach this goal in the near term, not a decade from now. Progress towards this nationwide data infrastructure should be driven by private sector innovation, with emphasis placed on secure data sharing to protect patient privacy, common standards in governance, and a ban on data blocking. In addition, we believe that Congress and the administration must address physician self-referral laws and federal anti-kickback statutes, as well as civil monetary penalty laws. These fraud and abuse protections were built for a fee-for-service world, but today they often stand as barriers to the kind of collaboration and information sharing that is essential for value-based healthcare approaches and for improving patient care. Another barrier to data sharing is the multitude of diverse and often contradictory federal and state laws regulating health information that exist alongside the federal HIPAA regulations. We believe these national and state privacy laws and regulations should be harmonized to facilitate greater information sharing for the benefit of patients while still protecting their confidentiality. Members of the committee, I would like to close by applauding you for conducting this hearing and your focus on the issues that can genuinely transform and improve health care for every American. We can move faster, we can move more collaboratively across the spectrum of U.S. health care, and we can help more Americans maintain or improve their health better than we do today through data, information, and insights. We look forward to working with you toward our shared goals, and I will be happy to take your questions. Thank you.
Thank you, sir. Mr. Savage, you're recognized for 5 minutes.
Good afternoon, Chairman Hurd, Ranking Members Liu and Cartwright, and distinguished committee members. Thank you for the opportunity to testify today. I am Mark Savage, Director of Health IT at the National Partnership for Women and Families, a nonprofit, nonpartisan organization that for 45 years has worked to improve the lives of women and families. We are deeply invested in improving the value and experience of health care and ensuring that new models of delivery and payment help make consumers partners in their care with access to the right care at the right time. I'm delighted to be able to share today the values, experiences, and needs of patients and consumers who are using health information technology, such as online access and electronic data sharing with doctors, to improve their health and care. The National Partnership leads the Consumer Partnership for eHealth Coalition and can speak broadly to the great opportunities that health IT presents and the obstacles that still make it difficult to realize its full potential. Health IT is the essential infrastructure for improving quality, care coordination, and value in our healthcare system today. It is a critical tool for engaging consumers who clearly recognize its value, according to a national survey we commissioned in 2014. We found that nearly 9 in 10 patients with online access to their health information use it. Notably, people who use online access frequently are much more likely than infrequent users to report that health IT motivates them to improve their health. Patients recognize that health IT is essential to improving their access to care as well as their access to their health information. They know what we know, that health IT helps patients and family caregivers communicate with their healthcare providers, share information, and manage their care, improves patients' knowledge of their health and empowers them to take charge of their care plans, allows patients to correct errors or outdated information in their medical records, such as a missing drug allergy, enables patients to share treatment outcomes, such as pain levels, functional status, and whether their health improved after the office visit, helps healthcare providers answer questions from patients by secure email, provide care with telehealth, and see the patients who need them most. Gives patients more control over how much personal medical information is shared and how it is used, and much, much more. Like electronic access in so many other parts of our lives, such as banking and retail, health IT enables real-time access to care and information and provides individuals with the convenience and control they need and expect in the 21st century. Health IT can also enhance patient trust and the privacy and security of patient data through encryption and other means. The country has seen a rapid increase in healthcare providers' adoption and use of health IT in recent years, but much work remains before the potential benefits reach all patients. We have an urgent imperative to break down barriers and continue the progress. First, That begins with removing barriers to health information. The national partnership runs the Get My Health Data campaign, and through it we have learned that many patients continue to face astonishing barriers to getting their digital health records from their healthcare providers. We need to change that by advancing policies and programs that promote patients' online access to and use of their health information. Second, we need to clarify privacy and security requirements for sharing health data because confusion persists about patients' access rights. That means, for example, adding proactive education initiatives about what HIPAA requires and what it does not, and encouraging mobile app developers and technology vendors to post their privacy policies and data sharing practices in standardized ways. Third, we need to enhance the usability of health information so that when patients access their medical data, they can understand and use it. For example, innovative apps could help patients organize their health information in ways they find most useful. And fourth, we need to bridge existing digital divides to help identify and reduce disparities in care. That means, for example, promoting online access to health information across diverse communities. And innovation in mobile apps can help. In sum, patients and consumers applaud the progress to date, and they need more. Patients have a unique vantage point, for they are at the center of the healthcare and information sharing we are all working to improve. Our goal must be to leverage health IT so it helps patients become real partners in their care and health. Only if we do that will we realize the full promise of health information technology. Thank you very much.
Thank you, Mr. Savage. We're going to keep going. We're expecting votes in about 10 to 15 minutes, so we're trying to get through as many members' questions as we can. And to kick us off this afternoon is the distinguished gentleman from North Carolina, Mr. Walker.
Thank you, Mr. Chairman. Appreciate the panel being here today and taking your time and being really a valuable resource for us. I'm married into the medical community. My wife is a family nurse practitioner at Wake Forest Baptist Medical Health Center. And every time I feel like I have, by osmosis, learned more medical knowledge after 23 years, she reminds me that I don't really have a good base of understanding. But this is something concerns. I remember even as a minister for 2 decades, sometimes trying to get information about a patient to family members or to others and trying to figure out how we can meet those needs, where sometimes there are problems to do that, even good laws. I also want to paint a picture here of some of the friends recently tagged along with a surgeon there at Moses Cone Hospital in Greensboro that has been so burdensome with some of the software and some of the regulation, it has impacted him negatively, as well as other physicians that have talked about this. So I want to address a couple of these issues. Maybe Mr. DiCrescenzo, if I could start with you. You both mentioned in your testimony obstacles. You also mentioned the word barriers. Talk to me for just a minute, if you would, about what specifically are the obstacles and barriers to getting where this needs to go.
Well, I think some of the barriers and obstacles, Representative, are some of the things that I mentioned and some of the other folks here on the panel. First of all, there's a lot of activity underway around collaboration in the industry, but it's one that we think needs to be supported broadly. We have both private sector and combined private sector and government initiatives, things like the Commonwealth Alliance, the Sequoia Project. There's technical standards from committees like HL7 that are trying to push the ball forward to make these systems talk to themselves, to each other, a lot more adeptly and easily than they have historically. I think support for that, as exhibited by the ONC report that came out last year, to push us down a roadmap where those efforts can be channeled into a way that they ultimately come to a harmonized approach between the state regulations and laws and standards, federal laws, regulations, and standards, and private sector initiative, really is one of the ways that we can make the most against some of the obstacles and barriers that exist today, where the systems don't have those standards to make it easier for them to talk to one another.
Thank you for responding to that. Are you familiar with Press-Ganey scores? Some of you are familiar with those?
Patient satisfaction scores.
Exactly right. So I want to make sure that we're also being an advocate for the healthcare providers, that we don't put those guys in a bind. In fact, earlier this morning, we had a very passionate hearing, compassion, I should say, as well, as far as the heroin, the opiates, and we know sometimes patients can be very manipulative in this process, And can you take a moment to maybe, Dr. Salvo, and speak to that to make sure that we're also, as we move forward with this, we're not putting our providers in a more vulnerable position?
Thank you for the question, Congressman. You know, as a doctor, I know full well the challenges that making sure that you're being compassionate, but also being evidence-based in the practice of medicine. Wanted to touch on the patient access piece because you mentioned it, and it's so critically important. The electronic health information is theirs. They have the right to access it, and we have worked with the private sector to see that we're creating innovative ways that they have more ready access to that information so they can make their own care decisions, but also it can be available in the care setting. And as an example, just in the last few months, working with the Office of Civil Rights, who has the primary responsibility for HIPAA and access, put out some guidance directed at consumers so that they would know what they had the right to access. This is a common refrain that we hear from consumers, but also from docs who want to make sure that the information's getting out. In the space of opioids, as an example, we certainly want to make sure that we're doing everything to support clinicians on the front lines. My husband's an emergency medicine doctor, and so this is a very everyday occurrence for him. And the tools like PDMPs, the prescription drug monitoring programs, that are electronic in many states and have really made it easier for us to access information to make sure that we're appropriately giving opioids to people who have pain or need it, but also trying to help folks stay out of trouble. And we've been working with SAMHSA and with states to see that those are more, and then with the industry to see that those become more aligned within the electronic health records. So you don't have to go to another place and sign on. That's added burden.
Before my time expires, let me also look at this. Healthcare is certainly very important as we move forward in having the right perspective. As a member of Congress, we also have a financial fiscal responsibility as well. We spend more than $2,000 per patient in any other country in the world. Can we make a case out of this that this is something that can drive us to be more healthcare cost conscious as well? Mr. Quinn or Ms. Rich, either one of you would like to address that?
So I'll use as the example Intel's Connected Care program, where Intel is a large purchaser of healthcare on behalf of its 53,000 employees in the U.S., said, how can we make our employees the healthiest in the country, retain them, and also try to save some money doing it. We've been very successful in the first two. The third has been more challenging, although there has been great progress there. The key to it, I would say, and this is also the key potentially for driving data sharing and information sharing in our broader healthcare system, is focusing on value-based care rather than fee-for-service. That was the engine that drove this, and we've seen a massive amount of actual use of this health information exchange because, of course, the technical pieces are there with the Sequoia project and building this, but also the incentives for using it are there for the healthcare providers.
Thank you, Mr. Quinn. Yield back, Mr. Chairman.
Yeah, the plan is to go to Mr. Connolly, and then we'll go into recess to get to votes. And now I recognize the gentleman from Virginia, Mr. Connolly, for 5 minutes.
I thank the Chair, and I thank Mr. Lieu and Mr. Cartwright for their gracious consideration. Thank you so much. I have 7 hearings in a day and a half, so I'm running back and forth. First of all, Mr. Quinn, thank you for sharing your story. Boy, could I relate to that. Both of my parents are in their 80s. And I've witnessed scenes where one is in the hospital in the emergency room and the other one is being asked to give the history, the medical history of whoever's. I'm thinking, what could go wrong with this scenario? You know, thank God they're both alert and have mental acuity, but, you know, memory sometimes fails us in moments of stress. And it's hardly an ideal system. And surely technology exists that would allow us to have a comprehensive picture of the patient in question without relying on human memory and such. So I really related to what you had to say, and I hope your dad's doing well. Dr. DeSalvo, picking up on Mr. Quinn's narrative, according to HHS's 2016 report to Congress on the adoption of health IT, your agency found that 97% of hospitals and 74% of physicians possessed a certified electronic health record system. But only 76% of hospitals and 42% of physicians with electronic health record systems were sharing the information for the coordination of care. Why that big gap?
Well, thank you for the question, and I certainly identify with Mr. Quinn also, both as a doctor who takes care of those kinds of patients, but also because of family members as well. And so, as I said in my opening, it's pretty personal to all of us to see that the data is moving. I think the good news story in the data that you present is that over the course of the last many years, we have dramatically increased not just adoption, but the opportunity to move and share data. So those are snapshot numbers, but if you look back at the trajectory, every year it improves both with doctors' offices and hospitals. We're not where we all want to be yet, but we are making progress. There are areas like the National Capital Region where health information exchanges like CRISP make that data available, such that if somebody arrives in an emergency room, their primary care doc will get a ping and be able to have the opportunity to send that med list or the problem list so that we'll actually know more about the person in the ER. And there are even more exciting advances happening, like in Mississippi, where the state of Mississippi has been working with local vendors to see that all of the long-term data from their Medicaid program is available to the doctors in the University of Mississippi Medical Center, so that when someone arrives, you have that picture like you mentioned.
No, you mentioned Chris, but I mean, doesn't that require a voluntary decision to participate?
So you are touching on the challenge that's emerged since we've been adopting electronic health records and moving to a digitized system, and that is that state laws vary.
Yeah.
And so there's some need to harmonize that.
Right, and that's a particular challenge here in the National Capital Region, since we have 3 jurisdictions with 3 different political cultures and sets of laws and so forth. And I have actually encountered that, where Maryland has one set of standards on this kind of communication, and Virginia has another, and we're not always talking what could go wrong with someone's health. I mean, you could jeopardize someone's health without intending to. Now, do we need, from your point of view, and I welcome Ms. Rich as well, or anyone else, but I mean, is this a case where, frankly, we do need to look at some federal legislation? I mean, we regulate blood supply for safety. Well, electronic record keeping isn't just a nice thing to have. In the digital age, it may be very critical to someone's health and the care they get, especially in an emergent situation.
In the short run, we have been working with the Office of the National Coordinator with the National Governors Association on developing a toolkit so the states themselves can harmonize their privacy expectations, so that won't be an unnatural impediment to information flow. Over the long term, clearly the health IT landscape has changed a lot since HITECH was passed in 2009. You know, we were on iOS 3 then, and now we're up to 6, just as one example, but apps and the cloud computing have really evolved. So we certainly are leveraging all the opportunities that we have at ONC and our partners at Office of Civil Rights and in other agencies to see that we're protecting consumers and that data is going to flow. But there are areas where we know that there may be some opportunity, like information blocking, where we would need some additional support.
Thank you so much for this fascinating conversation. Again, Mr. Chairman, thank you.
Sure. Votes have been called. The committee stands in recess until immediately following votes. Committee on Oversight and Government Reform, Subcommittees on Information Technology and Healthcare Benefits and Administrative Rules will get started again. I appreciate our witnesses and guests, patience as we went to go vote. We shouldn't be interrupted. And to get us restarted is my friend from California, Mr. Liu. You're recognized for 5 minutes.
Thank you, Mr. Chair. Dr. DeSalvo, in your opening statement, you mentioned data blocking. Can you explain what that is and how it works?
Certainly, Mr. Liu. Thank you for the question. Congress asked us to provide a report on health information blocking, which we did last April. And we thank you for that because it generated a national conversation and set into motion some actions that we've been taking in partnership, for example, with the Office of Inspector General, also with Office of Civil Rights, to see that we unblock data that has been collected in electronic health records. This is a new challenge we wouldn't have had years ago when we did not have a digitized system. It's emerged since 2009 when the HITECH Act put ONC and our authorities into place. An example of it would be that I'm a health system and my patient records have been collected or digitized, and my patient ends up in the emergency room at another hospital across the street, and for whatever reason I'm not sure I can share it because I don't understand HIPAA, or I maybe don't have a business associate agreement that I think I need to have to share data. And so when that patient shows up across the street, literally, the data is not moving, and it's just because of a lack of understanding. So that would be sort of an unknowing example, and by educating about HIPAA, which is something we've been actively doing, we hope to unblock that sort of data. Sometimes it's more around business practice. People want to hold on to patients or hold on to data and don't share it. So we have asked and gotten pledges from the health IT industry to say they won't block data. Now we're acting on making sure that we can put some teeth to it. But if I may, Congressman, it's an area where since 2009 the world has really evolved, and that's why in our budget request, we did put forward a proposal asking for some more opportunities for us to be able to address blocking. And to see that where data could move, that it would. And we really welcome the chance to talk with you more about the ways that we think that we could have more opportunity to address it.
And just so I understand, sometimes you have data blocking because the doctor or hospital may not have interpreted HIPAA correctly. Are there times where, in your opinion, they're intentionally doing it to gain a competitive advantage?
We've certainly heard plenty of reports about the use of it to gain a competitive advantage.
And what about vendors? Do vendors sometimes do that as well?
Occasionally, the way that will occur with vendors is they'll require added fees, unexpected fees, to create the interfaces, and that is a form of lack of transparency, but also can be a form of blocking.
And in the high-tech law, do you believe there are gaps that could address this? And essentially, what can this committee of Congress do to help with data blocking?
Yes, sir. What we've asked for in our as part of our budget request is some additional opportunities around defining it, and giving us the opportunity to require that vendors, for example, can't use gag clauses to prevent providers from talking about some of the contractual elements. Those are just a couple of the examples that we've asked for. So yes, we do believe that since the world has evolved, there's a new need for us to have some additional opportunities to protect the people who are using the systems, and more importantly, to protect the data of the consumers.
Let me switch to cybersecurity. Hollywood Presbyterian Hospital in Southern California had been attacked with malware, and they had to give a ransom to get their data essentially unencrypted and unblocked. 2 more hospitals, it was disclosed, were recently attacked in Southern California. What do you think we can do to help prevent those attacks? And my understanding is that, is it the Office of Civil Rights or that does the cybersecurity, and whether you think that would be the appropriate office or not?
The Office of Civil Rights does have the primary responsibility for privacy and security and for security breach investigations. We work with them in a variety of ways to see that we're educating providers, clinicians, and others to make sure that the functionalities, the capabilities in electronic health records that we require to keep the data secure are actually used in the field. We all know that there's a mix of both physical and cybersecurity expectations. So tools like our security risk assessment or tool is a way that we educate providers to know in a simple way how they can protect the data that's in there. So there are some opportunities that we leverage, but we work largely in partnership with the Office of Civil Rights.
And does that office have a team of computer folks that deal with cybersecurity issues?
It's a very tight partnership. They certainly have experts in the area of HIPAA and cybersecurity and privacy, and we work very hand in hand with them. We, for example, recently released some additional guidance for providers, but also for consumers about access and security, and have posted a series of joint blogs to make sure that there's a shared understanding of what security expectations there are. We work with them. You all, for example, asked us to ask the department to put together a cybersecurity task force, and we've been working along with others across the department to see that we put together that task force, and it just met for the first time last week, so we thank you guys for raising that issue.
Thank you. I yield back.
I'd like to pick up where Mr. Liu left off. So in OCR, so they have lawyers, because you said they understand HIPAA. Do they have technical folks that can actually help with a breach or when the next ransomware attack?
So, Congressman, I wouldn't want to speak specifically to the skill sets of their staff. What I can share with you is that the Office of the National Coordinator, which has technical staff, partners very tightly with the Office of Civil Rights, just like we do with other agencies, to make sure that we're bringing that talent to the table if it's necessary. Part of this task force, as an example, which is with the private sector, is to bring together the best minds in cybersecurity and to work with not only ONC, but OCR to see that we're helping to advance the healthcare marketplace to adjust to any new changes they need to in cybersecurity.
Ms. Rich, why is there so much confusion around HIPAA?
I can't speak to why there's confusion around HIPAA, but I do know that there's many entities that are outside of HIPAA that are under our jurisdiction, and that includes all the health apps and the websites that take in consumer-generated information. And that consumers may be confused about whether there is a regulation that protects their privacy in those areas, which is one of the reasons why we think there ought to be a regulation that protects the privacy and data security for the information collected by those entities directly from consumers.
Does FDA have responsibility in some type of regulation in this space?
The FDA regulates medical devices, and that includes some health apps, but generally they are looking at safety issues surrounding whether the app does what it says it does. The privacy and data security issues of such entities is generally in our care, and we have been working in this area for over 15 years, and we have an extensive program to look at the data security of these entities and take action, well, educate them to start with, and then also take action in appropriate instances.
So if it's a HIPAA violation, that's OCR's jurisdiction. If it's generally something else, it may be you, it may be FDA, it may be SAM, HSA, or the Patient Protection, PPACA. You know, there's so many of these different regulatory bodies, and my fear is that it's hurting innovation. It's hurting the proverbial two guys or two gals in a garage from creating something that can, you know, change the way that we deliver healthcare. And Ms. Rich, I'll get back to you on another question. And I wanted to ask Mr. Quinn, Dean, Cenzo, and Savage, and then Mr. Salvo, you answer after them. Meaningful use. This is a term that I've been hearing a lot over the last 16 months that I've been in Congress, and how it was originally designed to kind of spur companies from participating in EHR programs, but what I'm hearing is that it's actually getting in the way of innovation. I'd like for you three gentlemen to comment on y'all opinions on meaningful use, and Mr. Salvo, I'll let you be the cleanup batter. Mr. Quinn.
So meaningful use was quite successful in driving adoption of electronic health records. And without meaningful use, we wouldn't have the rates of adoption today that we see. As is the case with my dad's example, that each individual healthcare organization has an electronic health record and may be beginning to exchange data, doesn't mean that the net result of it is the coordinated care, the shared health information that we all need. And the prescriptiveness of this led some vendors and healthcare organizations to play to the test. What we need is to think ahead about the next generation of technology that's needed to embrace, for example, the Internet of Things, consumer-generated health data, the data that's being unearthed with the genome, and these other sources, and incorporate them into this so that we're not just thinking about this program as an end unto itself, but as an enabler of new technologies, new care models, et cetera.
Thank you. Sir.
Thank you, Mr. Chairman. I would certainly second Mr. Quinn's opinion that meaningful use, as it's been effective in the last few years to dramatically increase the use of EHRs, as Dr. Salvo mentioned earlier. In addition to some of the new technologies that he mentioned need now to be considered, it also suggests that over the last 4 or 5 years under meaningful use, we've learned a lot about how technology is used and what are some of the other process and incentive issues, and including things like reimbursement mechanisms that may or may not incent further use of electronic medical records and other types of electronic digitization of health information and the sharing around that. So going forward, we believe that we need to be thoughtful about what we've learned over the last 4 or 5 years as we look at additional regulation or requirements for expanding the use of electronic medical records and other allied technologies.
Mr. Savage.
So we agree that the Meaningful Use Program has been a major catalyst for improved adoption and use of health IT. And patients have been seeing a lot of the benefit of that. As I said in my testimony, there are still obstacles to overcome. More needs to be done. But with the Meaningful Use Program, in our surveys, we saw a doubling of online access from 2011 to 2014, from 26% of patients with online access to 50%. We see them using it for the kinds of things that are really critical for delivery system reform that is coming. So the access is as important, but the Meaningful Use Program is also set in 2018 to provide much more robust functions around patients sharing data with their providers, non-clinical data that is nonetheless relevant to care, better correction of errors, wearables, remote monitoring, and it will indeed stimulate the kind of innovation that we're all looking for. The version that's coming up also has APIs. We have tech developers who are writing apps for using those APIs. So important catalyst. The critical things are coming for patients and family caregivers to help them with their care planning.
Thanks to these folks, I'm just going to talk about the going forward because the health IT landscape and healthcare has absolutely been changing and evolving, and where we're looking to go forward after listening to providers, after seeing where the health IT landscape is to take the opportunity that was made from the doc fix or the macro legislation and make this program going forward more flexible, much more focused on clinical outcomes and on interoperability.
Thank you. Mr. Cartwright, you're recognized for 5 minutes.
Thank you, Chairman Hurd. I want to follow up that discussion with Mr. Savage a little bit. I think a cornerstone of the health IT field is the electronic health record, the digital version of a patient's paper chart containing not just the patient's current condition, but also his or her medical history. And I have here, looks like a poll, a Harris poll that MPWF commissioned. Is that correct, Mr. Savage?
That's correct.
All right, so this is entitled Engaging Patients and Families, How Consumers Value and Use Health IT. and I'll ask that this be made a part of the record, Mr. Chairman.
So moved.
So it's a Harris poll, it's a result of the Harris poll. I can't imagine how long this poll went, Mr. Savage, but it's pretty hefty. It was done in the spring of 2014, correct?
Correct.
And toward the end of it, there's a global summary, and it showed that more than 50% of patients want the ability to review their treatment plans, right?
Correct.
That nearly 60% wanted to see their doctor's notes, and that fully 75% of patients wanted access to their test results electronically. Have I got that correct, Mr. Savage?
Yes, we found great interest in all of those.
So that's the sort of information that would be available in an electronic health record, correct?
Yes.
Okay. Is it easy for patients to get access to their electronic health records right now?
The survey that you're referencing does identify increased numbers of access, so doubling from 26 to 50%. For those who have it, has become easier, but the national partnership has also done work with the Get My Health Data campaign, which has found that there are also people without the access that they need, and that there are some barriers. So I can either talk about on the survey side, or I can share with you some of the barriers we found with the Get My Health Data side.
The barriers I'm interested in.
Okay. So we found we have tracers, volunteers who report to us their experience with trying to get data, and everybody's story is unique. But we do find some commonalities among those stories. So some of the significant barriers are a very complex, time-consuming process in order to get access. So you and I in order to get access to our banking records, we may just go down to an ATM or access it through the internet. That's not a time-consuming process for the norm, but for access to health records, yes, it's been very time-consuming for these individuals. Records provided in a format that's not useful, you may ask for it in electronic format, you get a piece of paper by snail mail, misunderstanding of what patients' rights to access are, and perhaps one of the things that we've discovered most recently is the use of unreasonable fees before you can get access to your record. So that may take the form of, you've asked for your information, sure, here's the copy and here's the bill, and it's a bill that you never expected, surprise. Or you're charged a per page fee when it's an electronic record. So there's actually been, the Get My Health Data campaign has recommended that there be some comprehensive education initiatives to try to help providers and patients alike understand the requirements better. And the OCR guidance that recently came out provide some examples of the kind of innovative education efforts that we really do need to see.
Dr. DeSalvo, pick up from there. What kind of examples?
So that consumers have more access to their information than they did previously, though it's not where we think it needs to be. And as Mr. Savage mentioned in his earlier comments, we've been pushing through the Meaningful Use Program and through other ways to get increased consumer access. We, in fact, just put out a challenge grant through the Office of the National Coordinator, calling on the private sector to take advantage of this API expectation that we've put in electronic health records to create very consumer-friendly apps that would be on a smartphone and allow any patient to be able to access their health information and have more opportunity to control it. So we're really excited to see what the private sector is going to develop in the next few months to make it easier to get more access. The kinds of examples that get in the way of that, not technology, certainly Mr. Savage mentioned, but they are sometimes just a misunderstanding of HIPAA. The congressman had asked earlier why doctors don't understand HIPAA, and it's part of it that we're not really well trained in it in medical school. This is I think, a really important opportunity that the medical education field has along the way to see that we understand what HIPAA is and is not, and don't let it get in the way, though also the way sometimes it is enacted gets in the way of consumers having access to their information. It is, in essence, a form of blocking. And so again, back to this comment of the world has really evolved, and now there is data to be free, data to move, and the primary concern is to see that it's there for that clinical moment when you need it. But there's also many other important uses. So we're leveraging all the tools we have, whether that's education or clarity on rules and regs, but there's probably also some additional needed attention and maybe some additional supports to see that blocking is never a reason that people don't get their data.
So last question. My sense of it is that the better access patients have to their medical records, the better we all are in terms of patient safety. Does anybody disagree with that?
No,
Okay.
don't disagree.
Let the record reflect they're all shaking their head no, Mr. Chairman, and I yield back.
Thank you, sir. And now I'd like to recognize Ms. Lujan Grisham for 5 minutes.
Thank you, Mr. Chairman. I think I probably want to take off from where my colleague was leading you all, Mr. Cartwright. I actually think, in addition to the blocking and misunderstanding, that we've seen two principles in HIPAA be determined, and as an attorney, I feel bad about this, but sort of a legal opinion that you have two mutually exclusive premises. One, patient protection, and the other would be the portability of that information. And they err on the side, they are absolutely in their minds mutually exclusive, so they go to privacy. I just had this happen with a very large, very recently, healthcare provider who argued with me, which is, and HIPAA, I spent a lot of time dealing with HIPAA, so it wasn't I won. Because the CEO of the healthcare company refused to provide the patient information from provider to provider. And actually, I was trying to do him a favor, right? I've got labs that are 45 days out. I get a patient who calls my office as a constituent, says, I got to have them because my specialist can't do what they need to do without the records from this other provider. And I said, let me just call because I know I don't need really anything else. Provider to provider, just do it. And basically, I'm helping you because God forbid we find something in those labs that would indicate to your lawyers that you have a real liability. And then second, they wouldn't do it because HIPAA prevents that, as you all know, absolutely does not. But for the audience, does not prevent that. It explicitly provides for that. And then in addition, to make it easy for them, I was willing to get the patient on the phone with plenty of patient identifiers. And then HIPAA, according to this provider, also explicitly prohibits not having someone where you have really restrictive proof that that's the patient. And I said, that's nowhere in there. That's your own system, which gets to that it's proprietary, it's not interoperable, and that while we're doing, I think, great strides to make this information available, that unless we deal with that, you can't really create a patient record. I'd have to have apps for about right now. Let's see, I'm old, so that would work with about 47 different providers. And now that I'm lucky enough to have this job, I have to add all the providers that are in DC that I guarantee you don't speak to any of my providers in Albuquerque. So that was a typical for me, long-winded statement that our intentions here and meaningful use and all the incentives and including many of the accountability mechanisms really haven't gotten us to what we really want, which is very effective patient records. Because if you want patients to be part of problem solving, and you do, you know, if I get access to my record, I find all kinds of stuff that my docs didn't see because they're busy. I feel bad about that. I love them. They're my docs, so I really like them. Or my practitioners, but they don't have the time to search through stuff, and which is why every time you go, they got to do a whole new history because they got to ask me because it's much faster. But what happens when I am about 20 years from now? I can't remember for a whole variety of reasons. So, what additional incentives can we use? And give me, and you sort of floated around many, right? But I also want a milestone check. because I've also been working on telehealth for more than 2 decades. And quite frankly, the reimbursement issues and the other barriers really simply have not made it available in the places where the technology, not only in just physician-to-physician consultations or physician-to-patient consultations, but now you have the ability to do incredible online diagnostics. And yet, we aren't really doing it. So what are some really great milestones and mechanisms that this committee can help you achieve to that end? Anyone? All of you? Everyone?
Well, I'd like to just comment that I do think an obstacle to uptake on the part of consumers is concern about privacy. An obstacle to uptake of use of electronic records. Regardless of what a lot of consumers think about privacy in other contexts, we do know that they care a lot about privacy when it comes to their health records, which can reveal truly personal information. So from the perspective of somebody that's talking about privacy, we would like to see stronger protections that make sense. Yes, it's a balance. Stronger protections for data security.
Where do you see the balances so that and nobody, I think, on this committee is making any sort of statement that we should reduce privacy protections. But when they become an obstacle for that does not diminish the protection of privacy, we have a really big problem here. And I gave you one illustration, there are many. But what's a milestone to not diminish the protections that we're all interested in, but to get us to real patient records, serious interoperability, not just provider to provider because it's proprietary, but as you mentioned in an earlier meeting, within our hospital equipment, which creates huge patient outcome issues. That's not a privacy issue. And gets us to telehealth, all the different kinds of things I know that you all are promoting. And I don't know if the chairman's going to let me keep doing it. What a good guy. Can you talk?
Mr. Quinn can answer that question.
I would say a wonderful milestone is getting to 50% alternate payment models by 2018 as HHS has proposed, and that Intel, eating our own dog food, or as my colleague says, drinking our own champagne, including in Albuquerque, where we have a huge facility.
We'd like that to be bigger.
33,000 employees are today participating in our Connected Care program. And the real enabler of this is, of course, that there's something called the Sequoia Project that makes interoperability possible in connecting 150 different EHRs. But more importantly, that we are directly contracting with the providers in that area, and we have purchasing power. We're doing this in Albuquerque, we're doing it in Portland, doing it in Arizona. And Intel is a big purchaser, and we said, you're going to participate as part of this, and we're going to collect these metrics. The same is happening in this national basis as this 50%. 50%, I think, is a real tipping point, because you can't live in two different worlds. You can't live in the fee-for-service world and the alternate payment world. And the sooner we can get there, the better. We can't let up on the accelerator.
Okay, thank you.
Thank you, Mr. Quinn. Raise your hand if you have suggestions on how to harmonize privacy laws and which privacy laws and regulations need to be harmonized. No? Mr. Savage, y'all's organizations don't have opinions?
We do. We don't look at them as harmonization. We look at them as protecting privacy for patients in all the different states.
So I would like all of y'all to submit those ideas, those white papers, to the committee for the record so we can review those and see if that can be an area that we look at. And I would be remiss if I don't ask a cybersecurity question. And Ms. Rich, this is for you. And I'm not interested in any particular company or something like that. What do you think is the biggest threat right now to health information and our citizens' health data?
There's a few. One is failure by companies still to take this as seriously as they should. There's been a lot of progress in recent years, but we're still seeing not enough attention focused on this issue. Congressman Liu also mentioned ransomware, which is something that is on the rise and is particularly on the rise when sensitive information is collected because of the great interest in protecting that information, and so it's the ransomware tactics are more likely to succeed, and we're seeing that more and more in our cases, and we're looking at this issue ourselves and maybe doing something publicly on that. But the number one issue is still the failure to pay enough attention to this issue among many, many companies.
Mr. DiCrescenzo?
Well, obviously, Ms. Rich has her perspective, but I think at the HLC, we're taking this very seriously, and we see across providers, payers, pharmacies, everybody who's part of HLC, an enormous amount of investment and forward thinking on what to do about the problems that you described, for example, at Hollywood. I think one of the challenges that everyone needs to recognize is that we're also trying to constrain costs as much as is practical in the U.S. healthcare system, and all these things come at a cost, and there's not necessarily as much freedom, or maybe should there be, to be able to capture reimbursement in order to reflect those costs. So I think it's a very difficult area when you think of the resources that are applied anywhere from telecommunications to banking to other industries around cybersecurity. The fact that we've all described about the importance of personal health information and recognizing that many of these institutions, including many of the hospitals, I'm sure in your districts, are already struggling to deal with a number of other aspects of successfully providing patient care. So I think we certainly see people taking it very seriously, and as I'm sure you're aware, many people go into the medical profession because they have that commitment to patients, their data, and privacy. So I think one of the things we need to consider is how well is reimbursement reflecting the cost of doing a good job at it.
And Ms. Rich, what's been the biggest fine that FTC has issued on a private company for violating our privacy? We don't need to know the situation, just what's the dollar amount? And can you describe the situation?
We actually, in the initial instance, don't have fining authority in the data security area in general. We do when it involves kids' information or consumer credit data. But in the general data security work we do not have the authority to obtain any penalties, and that is, I think, something that we seriously need in order to create different incentives here.
If a private company would have lost the information on 23 million records, what would FTC have done?
Well, in the abstract, it's hard to say. Each violation, if we had civil penalty authority, just borrowing from the authority we have in other areas, every violation could be amount to a $16,000 penalty. So if you add that up over millions of consumers, it's potentially infinite, but of course we take the ability to pay, et cetera, into account. But the fines could be quite high for a company that had very serious violations and injured a lot of consumers.
Great, thank you. And now to close us out, Mr. Blum, you're recognized for 5 minutes.
Thank you, Chairman Hurd, for holding this most important hearing, and thank you to all the panelists today for your insights. Appreciate it very much. Telehealth, telemedicine has absolutely intrigued me since I've been in office the last 15 months. When we talk about rising healthcare costs in the country, I know many citizens want a silver bullet. You know, one answer, one thing's going to solve the increasing healthcare costs. And I kind of believe, and pardon my pun, but I believe it's been death by 1,000 cuts, the increase in healthcare costs. It's been a lot of small things. And I think one piece of the puzzle, the solution to keeping healthcare costs in line is telehealth or telemedicine. And particularly in our veterans care system with the psychiatric care with PTSD. I know in Iowa it's rural. So we don't have a lot of, in all of the outpatient clinics for vets, we don't have a psychologist or a psychiatrist on staff. So telemedicine is a great application there. I'd like to ask, all the panelists, what policy changes do you think are necessary so there's 100% telehealth participation by the providers and by the hospitals? Because I just see it as, I see it as critically important to saving the government money and also improving the outcomes of our patients. So whoever would like to take that, jump on it, please.
Congressman, perhaps I'll begin and say that I share your enthusiasm for telehealth. As a doctor, have had the opportunity to use that, particularly for access to psychiatric care in my home community in New Orleans after Katrina, when we had really a lack of services. And as a rural state, we've been able to leverage that as well. As a care delivery model, very well received, can also save people money because they don't have to take off of work and find childcare, et cetera, to go to the sites. It's less of a technology issue and more of, I think, an opportunity as we move to alternative payment models. So as the VA has been able to show, and the private sector, and certainly through some of the work that the department has done with these models in the Center for Medicare and Medicaid Services, we've been working to advance that as an administration in partnership with the private sector. I think it's something that we see as a department, an opportunity in the delivery system reform work that's moving to alternative payment models, such as in the macro legislation that's required for docs. It's going to give us a lot of opportunity to really enable and support new kinds of care models. So from our standpoint, we believe that with the department, we really believe that we're moving forward into this world, and that the macro legislation for docs in particular is going to be helpful.
Since you're a medical doctor,
Yes.
correct? And I know you can't speak for the medical community, but what's your impression or your opinion of the medical community's opinion of telemedicine? I mean, is it a good one, or do they say like, this isn't that good of stuff?
So I can't speak for the medical community. So
Admittedly.
I'll speak for myself and my peers that there are some real benefits to it. Speaking purely as a doctor, I think one of the challenges is there's a lot that you gain from being in the room with the patient. You can touch them, you can listen to them in a way that you can't necessarily through technology. So a mix of kinds of interaction is typically what we want. We wouldn't want it to all be remote, because you also gain something from that touch, in that exam room.
Others would like to? Yes, sir.
Congressman, one other thing I'd mention is harmonization of standards across the states. Obviously, with telemedicine, as you described, it's something that brings the ability to provide care across a distance. And of course, many of the states are quite large, so it's urban to rural and various other ways that certainly would facilitate the growth of telemedicine in a very important fashion. But in addition, there's quite a patchwork of regulations and standards on a state basis across the country. So the ability to leverage perhaps highly specialized care outside the state is often more difficult for somebody looking to put together a national network, or even nationally focused providers like Cleveland Clinic and others who have a very large footprint across the country.
And what would the solution to that be? Is there an easy one? Or I like easy solutions.
Yeah. Well, we have 50 states, so I doubt there's an easy one. But I think there is increasing, I would say, similarity between the regulations in different states as they become more familiar with this. And perhaps like a lot of the work ONC and others have done around harmonization of technology standards, we would hope that also be a similar effort to harmonize the standards and regulations around telemedicine.
Yes, ma'am.
The FTC in the competition area, which I don't personally work, but we've done a good deal of work on breaking down barriers to competition that may hold back certain alternative forms of medicine. And for example, we've commented to states that may have laws that favor certain medical techniques over others, and in a way that interferes with competition. Through state laws. So competition is very important in this area.
Do I have time for one more question, Mr. Chairman? What are the major barriers that are preventing a focus on home-based health care versus expensive hospitalizations? It's another area I am very interested in, is keeping that person in their home as long as we possibly can, or getting them back to their home as quick as we can. Thoughts on that?
Well, I would jump in and say that that's a good illustration of perhaps an interoperability issue. We want to make sure that the patient's home is connected with the systems. So you want access. You want the patient to be able to send remote monitoring information to the doctor's clinical record. These are things that are actually in process of being developed on a national level. That kind of two-way communication between the home and the doctor's system also contributes to care planning. so that you actually have working together to manage the care and to move from care to health.
And this could apply to nursing homes as well, correct?
That's correct.
So I would say that one of the things that really is lacking today is ensuring that those home-based applications have a market. So today, without the reimbursement for many of those things, the market hasn't blossomed the way that it could. And many of the applications and the tools aren't necessarily designed for a 78-year-old or maybe someone with disabilities who's at home, and ensuring that that frankly consumer marketplace with the technology that's rigorous enough to be trusted and incorporated into the healthcare system is built, and that there's a marketplace for it because there is reimbursement, there is a path for investors to say there's something here.
That's a good point. Thank you very much for your input. I appreciate it very much. And with that, I yield the time I do not have.
I'd like to thank Mr. Liu and Mr. Cartwright for the bipartisan nature of working on this topic. It's important for an exchange of information. I appreciate our witnesses for taking the time to appear before us today and for your patience. And if there's no further business, without objection, the subcommittees stand adjourned.